and welcome to Tala Talks NICU. I'm Dr. Tala, and today we are going over part 2 of CDH, or Congenital Diaphragmatic Hernia. So if you haven't seen it already, go and watch part 1. So in part 1, we already discussed that a friend or relative of yours was 20 weeks pregnant and just got her ultrasound done and found out that she had a CDH. She has a billion questions for you. So in part 1, we went over exactly what is a CDH, as well as the prognostic factors. And in this video, we're going to go over the management of CDH, so you have kind of a good idea of what to tell your friend or relative, as well as to actually take care in the unit, as well as the outcomes of CDH. Again, I'd like to give a massive thanks to Dr. Chandrasekaran, who is at the University of Buffalo, and Dr. Satyan Lakshman-Narasimha, who is at UC Davis. Amazingly, Dr. Satyan actually drew a lot of these illustrations in this absolutely amazing review on CDH, and I've referenced it below, but all these illustrations that you're seeing throughout were actually drawn by this neonatologist, Dr. Satyan. Amazing, thank you. Right, let's start with how to manage CDH. And our first question obviously should be, can anything be done prenatally? Well, in animal models, steroids look like they may confer an advantage to fetuses with CDH, but this didn't really pan out in neonates. However, if a baby is going to be born prematurely, then definitely you should be giving them the benefit of steroids. Otherwise, they don't really have a role. What about prenatal surgical interventions? Well, for some time, everybody got really excited about a procedure called tracheal plugging. So while the baby was still in utero, they would go in and put a substance into the trachea. And the hope would be that by plugging the trachea, the fetal lung fluid is kind of trapped in the lungs, and it would kind of force better development of the lungs. This was actually pretty successful in animal models. This improvement didn't really pan out in neonates, apart from in infants with really severe CDH that had slightly improved survival at 1 and 6 months. However, as you can imagine, any time that you're doing any sort of prenatal intervention and going into the amniotic sac and everything, there's going to be a slightly increased of premature rupture of membranes. And that is actually what they found in the study. And it was found that having some sort of intervention actually lowers the gestational age by about 2 weeks. So it's not really known exactly what can be done prenatally. Hopefully this will be a good field of research in the future, because if we could solve this problem before babies were even born, then that would be the best solution. Obviously, we know that these babies can get really sick, and they need to be delivered in a center with multidisciplines available. So there needs to be the neonatologist and the surgeons and the ECMO specialists, and really lots of other subspecialties that can take care of this baby. So make sure that's one of the first questions that you ask your friends. Make sure that they are delivering somewhere that has the capability of taking care of a baby with a CDH. As you would expect, these babies do better if they're born term versus preterm. Obviously, if they're born really preterm, they can't even go on ECMO if they need it. But another study found that not only do they do better if they're born term, but also later in term, they do better as compared to early term. So if a baby is born at 40 weeks, they do better than if they're born at 37 weeks. So again, if this baby has a CDH, then you should not be doing like an elective C-section at 38 weeks. It should be at least 39 to 40 weeks. Before I go over the management more, there's a concept that you really need to understand how to take care of babies with CDH. So I am going to spend just kind of a couple of minutes going over it. So as you all know, babies with CDH are predisposed to get pulmonary hypertension, and you've all taken care of babies like this. But there's more than one way that actually contributes to that pulmonary hypertension. There is a irreversible or fixed cause of the pulmonary hypertension, and then there's a reversible cause of the pulmonary hypertension. And I really want to go over both of those now. So let's go over the fixed or the irreversible pulmonary hypertension first. So like we said, in utero, when the intestines are going up into the chest, the lungs are underformed. So there are fewer bronchioles, there are fewer vessels, there are fewer alveolar sacs. So because the lungs themselves are hypoplastic, there really isn't enough lung to be able to accept all the blood volume. So the same amount of blood volume is pushed through a smaller amount of blood vessels. So obviously what's going to happen? The pressure in those blood vessels is going to go up. There isn't anything that we can magically do to actually increase the baby's lung volume. Eventually the baby will grow lungs, but this takes months and years. There isn't anything that we can magically do in the unit to reverse this type of pulmonary hypertension. So if the baby really doesn't have enough lung and all that blood is just being pushed through tiny volumes of blood vessels, then there isn't necessarily anything we could do. No amount of mechanical ventilation or ECMO is going to actually grow us new lung. So that really is the first question that we're trying to get to the bottom of after a baby is born. Does this baby have enough lungs to actually be able to survive? So that type of pulmonary hypertension is fixed or irreversible, and there isn't really a lot that we can do about it apart from try not to make it any worse. Then the other type of pulmonary hypertension is the one that we're all more used to. So that is the reversible type of pulmonary hypertension. And you all know how that happens. So basically, if a baby lacks oxygen at birth, then the pulmonary vessels constrict. So this causes the pressure in the lungs to go up. So when the pressure in the lungs go up, less blood may end up going to the lungs, and so the lungs see even less oxygen, so they end up constricting even more, and you can end up with a pretty severe vicious cycle of pulmonary hypertension. This is a similar type of pulmonary hypertension that you would see in meconium aspiration syndrome or sepsis, for example, and we did a whole video on PPHN that you can go and watch after this. So really, when we're taking care of babies with CDH, there's two big management guidelines that we're trying to follow. The first one is that we're trying to avoid the reversible type of pulmonary hypertension. We want to stop the baby from going into it, and if they do have any reversible pulmonary hypertension, then we need to try to get the baby out of it. And then the second one is we have to protect the lungs as much as possible to prevent further injury to the lungs, in the hopes that if the lungs stay okay, then they'll be able to support the baby. So prevent further injury to the lungs. Now you understand those concepts well, let's go back over the kind of more specific management plans for the baby. Again, remembering that what we're trying to do is support the baby without further injuring the lungs. So one, let's start in the delivery room. Just like every single other baby, you would want to follow the NRP guidelines, except for the one caveat. These are not babies that you would want to give positive pressure ventilation to with like a bag mask. And why wouldn't you want to do that? Because when you're giving bag mask ventilation, you're not just pushing oxygen down into the lungs, you're also pushing it down the esophagus, into the stomach, and into the intestines. So what will happen if you push even more air down into the intestines? Well, if the intestines are in the chest, then those intestines are going to get even bigger and collapse the lungs even more. So it really could end up a lot worse by actually giving these babies PPV. So if you are pretty confident that the baby does have a CDH, or the baby in any way looks like it's getting into respiratory distress, then these are babies that you should be intubating pretty soon after delivery. And then using the same logic, you also want to decompress the stomach and the intestines as much as possible. So pretty soon after delivery, you have to put in an orogastric or a nasogastric tube and put it to suction so you can get all that fluid and air out, and hopefully allow the lungs to kind of expand a little bit more. And then again, to reiterate, be really gentle with a baby's lungs. So even if you're stressed and in the delivery room and somebody just got intubated, don't bag these babies with a lot of pressure. Try to keep the pit below 20 to 25 centimeters of water. nice, gentle bagging so that you're not causing further damage to the lungs. And then follow the amount of oxygen that you're giving according to the NRP guidelines. You don't want a state of hyperoxia either. Then, when you get these babies to the unit, they're going to need lines. So you want to put in a UAC and a UVC so that you can measure the blood pressures and check the gases and give medications in a consistent way. Just as an aside, remember that an arterial umbilical catheter is a postductal arterial catheter. So basically, you would expect that in a situation with PPHN or with just general pulmonary hypertension, that the postductal SATs and PaO2 are going to be lower. And in the interest of being gentler to the babies, it is better for the baby that we should follow the SATs or the PaO2 in a preductal place. So basically the right hand. So just remember that when you are using the PaO2 and the pH and everything from the UAC. And then obviously you're placing the baby on a ventilator. There has been so much discussion about what is the best ventilator to put babies with a CDH on. And nobody really knows what the answer is. You can probably start on a conventional ventilator, but you just have to be certain that you are going to give them very, very gentle breaths. So if babies start needing higher pressures on the conventional ventilator, so for example, higher than a 25 centimeters of water PIP, then you should probably be transferring the baby over to an oscillator or to a jet or whatever. So whatever ventilator you use, make sure that you use it gently. To make sure that the organs are getting all the oxygen they need, we need to make sure that the baby's blood pressure is good. So careful attention needs to be made of the perfusion, of the blood pressure, of the urine output. If there seems to be an issue with any of these, then the baby needs to be given volume or started on medication. Really, we need to do a whole video on inotropes. We used to always routinely start dopamine on babies with low blood pressures, and now the neonatal world has realized that there really isn't a one-size-fits-all inotrope. So basically, the inotrope that you'd want to start is going to depend on what the heart is doing, on what the kidneys are doing, and what the blood vessels themselves are doing. So maybe you'll start dopamine, maybe you'll start dobutamine if the heart isn't functioning well. You could also start epi or norepinephrine or even vasopressin. If the hypertension appears resistant to all of these drugs, then you may have to start hydrocortisone as well. Like we already said, we are worried about high pressures in the lungs, and we're worried about how the heart is actually affected by these high pressures. So pretty soon after you get the baby to the unit, or within the first 24 hours, you should be getting an echo or an ultrasound of the heart. You need to actually look at the anatomy of the heart because, like we already said, having a CDH may increase the risk of having anatomical abnormalities in the heart. But also you want to look at the function of the heart. Is there any amount of failure or dysfunction of any of the chambers? We also use the echoes to indirectly measure the pressures in the lungs. And again, go back and watch the PPHN video to see how we use the echo to kind of estimate the pressures in the lungs. If an infant does have pulmonary hypertension and a really high oxygenation index, so kind of above 20, we made a video on that, go and watch it, then one of the medicines that we're used to using in the NICU is inhaled nitric oxide. But interestingly, INO or inhaled nitric oxide in infants with CDH in prospective studies has not been shown to decrease the incidence of death or decrease the need for ECMO. And why would you guess that that is the case? And I know you know why. Because a lot of the pulmonary hypertension in CDH is fixed, which means there just isn't enough blood vessel volume for all that blood to go through. What INO does is it dilates the arterioles. So it relaxes the smooth muscles around the blood vessels and dilates them. So obviously that's going to increase the volume a little bit, but if there just isn't enough volume of the blood vessels, and you're maximally dilating them, then you're not going to suddenly magically reverse the the pulmonary hypertension. But as you can imagine, if a large part of the pulmonary hypertension in CDH is reversible, so for whatever reason this baby got hypoxemic, maybe you didn't know that the baby had a CDH, maybe the baby was transported in from somewhere else and we just got behind, then maybe INO would help in those babies, because actually one of the main problems here is that the arterioles are really constricted. So if we dilate them, then it will be just enough to decrease that pulmonary hypertension. The good thing is, as you know, if INO is going to work, it's going to work really quickly. So often we can just start INO in these babies, and if it's really not showing any effect within a couple of hours, then this can be weaned off. There are other medications that we do use in infants with CDH, and I'm going to kind of go over these pretty briefly. One of them is prostaglandins. As you all know, we use prostaglandins to keep the duct open. So if the right side of the heart is having to pump against really high pressures in the lungs, then what we worry about is that right side of the heart will eventually fail, and then this is a disaster. So sometimes we use prostaglandins to actually pop open the ductus to give kind of a pop-off valve so that the right heart has a way to pump out the blood that isn't just against the huge pressure in the lungs. Prostacyclins, this includes Flolan, which you probably heard of being used in older kids and adults. There isn't a lot of data in neonates, but still some centers will use Flolan. Sildenafil, which I'm sure you're all pretty used to using in the unit. And again, not a lot of data on this, but it may prove very helpful. As you all know, it can be given like as a tablet or as an IV form. It can be very helpful in places that don't have INO or ECMO. And then milrinone. In animal models and in infants who have just had heart surgery, this drug is fantastic. It increases the contractility of the heart, and it kind of it relaxes the vessels in the lungs. So really exactly what we would want. However, there isn't great data on babies with CDH using it one way or another. Many centers do still choose to use it. And then let's talk briefly about ECMO, or extracorporeal membrane oxygenation. And I'm sure a lot of you know this, but basically it's when the baby is effectively put on an artificial lung / artificial heart as well. So 2 big tubes are put into vessels, normally kind of in the neck, and one of the tube that goes into the vein drains the blood. It takes it through an artificial lung and then pushes it back into the other vessel. This is used as a last-ditch life-saving resort in babies that are above 34 weeks and above 2 kilos that don't have any other associated severe anomalies. ECMO really doesn't have convincing data that it increases the survival in babies with CDH, but you can imagine that this is a really hard study to actually do. If you are the parent of a dying baby with a CDH, you're probably not going to enter a study where the life-saving possibility of ECMO is not being offered to you. So the thing about ECMO is that you are just putting them on an artificial lung. You're not fixing the lung. So babies should only be placed on ECMO if they have a reversible lung injury. So going back to what we said with babies with CDH, we don't always know whether they have enough lungs to actually be able to oxygenate the baby. And so we put them on ECMO just kind of hoping that they are going to have enough lungs. They're not going to be on ECMO long enough to actually be able to build new lungs where they can now actually breathe. As you would imagine, the shorter the amount of time that infant spends on ECMO, the higher the survival. Although one study showed that with infants with CDH that had spent 4 weeks on ECMO, the survival was still 43%. After 4 weeks, the survival plummets down to about 15%. Now let's talk about the actual surgical repair. As we kind of talked about, because it's the actual problem with the lungs rather than the intestines being in the chest, generally surgeons aren't in a huge rush to fix the hernia as quickly as possible. But other institutions are like, anything that we can do to allow expansion of the lungs at all would be helpful. So other institutions will actually repair pretty soon after birth. Just hoping in any way that the lungs are going to be better expanded. So when the actual repair of the hernia is done is also very controversial, whether it's immediately after birth, a few days after birth, or even when the baby is on ECMO. And then when do you do it when the baby's on ECMO? Immediately after ECMO or after you realize that you can't get the baby off ECMO? Ultimately, what needs to be done though is that the intestines and stomach and abdominal contents need to be brought back down to the belly, and then the diaphragm needs to be closed. That's what needs to happen with the surgery. Again, different surgeons do the surgery differently. It can be done open, or it can be done kind of more closed with a thoracoscopic camera or something. They can also go in from the chest, or they can go in from the belly. I will not speak more about this because this is all surgeon's territory. I will say though that sometimes the hole in the diaphragm is small enough that the surgeon can just kind of suture it up. Other times the hole is too big and the babies need an actual patch over the diaphragm, and normally some sort of artificial material is used like Gore-Tex to kind of make that patch over the diaphragm. As you would expect, the infants that need the patch generally have worse pulmonary outcomes. Okay, so that was the management. Now let's talk about the outcomes. We've kind of talked already about the general survival, and honestly the prognosis changes so much depending on the anomalies and on how bad the CDH is and everything, but generally it's somewhere between 60 to 90% survival. If babies are on ECMO, then the survival is about 50%. And nearly all of the deaths that happen from CDH happen between 2 to 6 days of life. But as we've talked about, this survival is really dependent on all those prognostic factors. How big is the CDH? How long were the intestines up in the chest? Is the liver up there? Are there associated anomalies? Was the baby born in a center that can take care of babies with a CDH? All of these things will really affect the survival. Although I will also say this, that is, survival numbers don't really mean a lot to a parent. Your baby either survives and it's 100%, or your baby doesn't survive and it's 0%. Saying these numbers to parents, 60, 70, 80%, doesn't really mean a lot. But in addition to increased mortality, there's a lot of morbidities that are also associated with CDH. So let's start with the lungs. As you would expect, these babies often have some chronic lung disease where they can end up needing oxygen for a long period of time. They are at increased risk of having some rebound pulmonary hypertension. They can also have symptoms of obstructive pulmonary disease. If these infants were on ECMO or they needed the patch closure, then generally their respiratory symptoms are a lot worse. A lot of the survivors that go into their teens will need kind of the bronchodilator therapy, so like the albuterol or whatever, and they will have decreased inspiratory strength. As you would also imagine, a lot of these babies have feeding and GI and nutritional issues as well. A lot of them have problems feeding. They can not even start taking PO feeds for weeks or months of life. And so a lot of them end up getting kind of oral aversions. A lot of them end up needing a gastric tube or a G tube, and they fed that way. They also have a lot of problems with GE reflux or gastroesophageal reflux, because if you think about it, the throat and the stomach were kind of all over the place. So definitely an increased risk of refluxing. Babies who are diagnosed with CDH generally spend between 2 to 3 months in hospital. And so, as you would expect, with that and the feeding issues and the breathing issues, that these kids are at increased risk for developmental issues as well. Hearing loss is more common in these babies as well, especially if they were on ECMO. And that brings us to the end of our CDH videos. Again, I want to thank Dr. Chandrasekaran and Dr. Satya and Lakshmin Nrsimha so much for their papers and for allowing us to use the illustrations. Please remember to like this video and to subscribe to this channel if you're interested in neonatal content. And if you write into us, please let us know where you're from. We love hearing from everywhere in the world everybody is from. Thanks so much for being here.